That's the topic for today. That is the action potential. A bit early. Start at 10. Then start. One. Start the topics. There were few emails, but we won't be able to repeat the entire thing. So what I'm doing is that we won't be able to repeat the last times. But yes, we'll just get a overlook about what exactly was discussed. Even if you have not understood or even if you're not last time's lecture. And I'll try to make it as simple as insulin resistance later. Yeah. In fact, there would be a complete big topic on insulin, a huge topic. It should be lasting for about 3-4 days. We'll be discussing it at length because it is insulin resistance is not the end of the world. In fact, the diabetic ketoacidosis and so many things. So it will come. It is part of the world. Okay. So we talked about membrane potential. It was the membrane potential. And what is the potential? That if this is the cell, you put one electrode outside and one electrode inside. So then what is the difference between, what is the voltage difference between outside and inside? And when we consider any of these today's discussion or all of the discussions which are related to membrane potential, we'll be telling that we are actually sitting inside the cell, and that's how we'll be evaluating all the potentials. That means when we say it is electronegative, that means inside of the cell is electron with respect to outside. So this is the ICF, intracellular fluid, and this is the extracellular fluid or the extracellular environment. So we'll always be checking with respect to this. This is one. In the membrane potential, there will be two. One, which was discussed last time, that was the resting membrane potential. Resting membrane means when just two things they are working. One, the potassium channel. Second, sodium potassium pump. Sodium potassium pump, which is active using the ATP. Potassium, no, it is not active. It is a passive pump, always open. So it is like a leakage, right? A small amount of this potassium is going this side or that side, depending upon where the concentration is. And today we'll be talking about the action potential. In fact, not today, but in the next few sessions, at least 2-3 sessions will be about this. So we have to discuss and we have to understand this thing in complete detail. Action potential in neurons, because it will tell us about the nerves. Action potential in case of cardiac, so that would be the most interesting of all. Not only that, cardiac, we will also be talking about the pacemakers. There is a difference between cardiac muscles and the pacemaker. Pacemaker is what is firing those impulses. And with the tune of that impulse, right, cardiac muscles, they keep on contracting. So we'll see that what really happens in all these cases, and obviously the skeleton, right? Skeletal muscles. So that's how things will be going. In case of pacemaker, it's SA node. It is during this discussion, we'll also be discussing about the ECG, because that would be the right time to talk about ECG. As you'll be learning about action potential, you'll parallelly see that what is happening in ECG. So it will make your understanding not easy, but you'll be able to understand it very fast. So here is something which you already know. This is what we are drawing is a neuron. That's our neuron. And in neuron, there is, because this will be our chief guest for neuron. And so there is a nucleus. This entire thing, which is called as the cell body, right? This upper portion, this is the cell body. And then there is, this is what is called as the axon. Axon. This axon, just make some space. This axon is covered very by, that is what is called as the myelin, by the myelin sheath. The sheath, yeah, exactly, myelin sheath. And in between this space, right, in between, it is not a continuous sheath, right? It's exactly like this, comes and goes, right? So it is like this, and in between space, that is what is called the of Ranvier. No, of Ranvier. And these nodes of Ranvier, they are very important for two functions, because this is the space where there will be lots of sodium channels. Right? They are the maximum sodium channels they will be present over here. We'll just discuss in a while that why it is so important. Also, this myelin sheath, it is a sort of insulation. Right? It is a sort of insulator. This myelin. So it prevents the dampening of the signal. So signal is not dying, right? Signal can continue for a longer distance. So that is one of the functions. Second point, that it improves the speed of the conductor. Speed improves, right? Speed improves. And later on, we'll see some of the clinical aspect when the myelin sheath is affected. So what would really happen to such patients? So it improves the speed. Speed means it is the speed of conduction, right? Speed of conduction. Speed of conduction is all right. Now, this is the cell body, and in this entire cell body, there would be some rough endoplasmic reticulums. Rough endoplasmic. When we say rough endoplasmic reticulum, that means on this endoplasmic reticulum, on that, if the ribosomes, if they are present, then we say it rough. If it's not, then we call it smooth. Over here is the rough endoplasmic reticulum. And this rough endoplasmic reticulum, over here, there is a specific name given, and that is what is called as the Niesel's body. So yes, we need to remember, this is what is called as the Niesel's body. So but this much is the structure, and that's how it will continue. That means these are the dendrites. These are dendrites. So where they will be getting connected with other neuron, and then the whole current would be conducted. Neuroplasmic reticulum, I don't know. This is because this is the Niesel, means the name of the person. Niesel's granules, you can see. So over here, this would be in connection with other neuron. Right? So this is like, say, let's say another neuron which will be connected. So this particular junction is what is called as the synapse. Synapse. That is called as the synapse. All these, in putting in simple words, if I do it like this, these are the neurons. So over here in this much, there is electrical conduction. The current is going. Right? But in between, right, there is no physical connection. There is a gap. Right? So it is at this point where there is a chemical process running. That chemical process is nothing but the neurotransmitters. So when we'll be discussing in detail about those neurotransmitters, that is how they will conduct. Right? The foundation would be channels. What will be. So here, as the current would be traveling, traveling, means the cell will become positive. That means it is depolarization. We are interested in all the way from negative, inside of the cell is becoming positive. That means we'll be talking about depolarization. No. In our body, there are electrical and chemical synapses. No. There are synapses, they are always chemical. Synapses, they are always chemical. There is always a neurotransmitter, whatever the neurotransmitter is. Right? So that means, practically speaking, if this is one neuron, right? If this is one neuron, and these are the receptors. So there is always a gap. There is a gap. And this conduction is always by the neurotransmitters. Neurotransmitters, how they will work? Because these neurotransmitters, they will be opening, they will be getting connected to those receptors. Acetylcholine, adrenaline, so many. But whatever the neurotransmitters are, but there will be the receptors over here. And these receptors, they will be activated, and that's how that entire game starts. What we discussed. So depolarization, that means cell is from, and in detail we'll be talking about in detail just in a minute. So negative to positive, this will be our, that is what is called as the depolarization. As we explained, right? We just talked that this is the cell. Just think it that we have got two probes, one is outside, one is inside. So this will be more negative as compared to outside. Cell is more negative. If they both are on the same surface over here, then there will be a potential difference. So this is technically called as the potential difference. What is the difference between both of them? The difference in the voltage between both. Node of Ranvier, we talked about. Sending the signal to the neurotransmitter. Exactly. It is the neurotransmitter. Without neurotransmitter, see, I'll take a minute for it. Say over here, just consider this is upper neuron, this is lower neuron. But in body, there is nothing like upper or lower. So that's why there is a technical term. This is synapse. Synapse is that junction where two neurons are. So this is what is called as the presynaptic, and this thing is called as the side is called as the postsynaptic. Simple. So this gap. So over here, those receptors, right, they are sitting, and then over here in the vesicles, there are small balls in which the neurotransmitters are filled. As soon as the calcium channel signals come, right, all of them, they will run towards the surface and they will release their neurotransmitters into this space, So that neurotransmitter which will come over here, land over here, this receptor will be happy, right? And then he'll be sending inside signals. The inside signals are sent, and then the whole thing starts. So all the GPCRs, right, when we talked about G protein coupled receptor, so what was that? Similar. We said that after completion of that entire process, right, which three things? Gene, correct? Then ion channels, they will be, and the enzymes, they will be released, right? So ion channels and the gene expressions. But so these are the things. Over here, we'll be focusing on ion channel. That is when the neurotransmitter comes. That particular neurotransmitter will open certain channels. Right? It will open certain channels. And then there will be movement of sodium, potassium, calcium. All those movements will start. Now, those movements are the resultant movements. Those movements will lead to the final resultant potential difference. That's how the cell becomes more positive and how it becomes negative. That's the game. That's what we are supposed to learn. So we said that potassium constantly working. So that this is a passive one. Right? There is passive diffusion for the potassium channel. There is a problem. Passive diffusion. And in cell, we have got more potassium. Inside there is more potassium, and outside there is less. And if there is a door which is open, so obviously potassium will start traveling outside. Right? Potassium is going from in to out, and that is what we'll call as efflux. E is for exit. So this is the efflux of potassium. So when the potassium is lost, when it is going out, so it is going out, and that is why this is giving us the resting membrane potential. So cell is negative. Cell is negative. Right? So resting membrane potential, that is by minus 70 millivolt, which can be measured. So resting membrane potential, it varies from tissue to tissue. Very grossly, when we talk about the neuron, these three are usually the neuron, skeletal muscles, and the cardiac muscles. Right? Cardiac muscles. So over here, this is neurons, it is about minus 70 millivolts. In case of cardiac and the skeletal, it is about minus 90 millivolts. So these are the roughly few points up or down, but these are the normal resting membrane potential because it's a very dynamic system. And what happens is that there is a big change. There is something which we need to know about the pacemaker. Every muscle can rest. Neurons, well, in some of the nerves, there is no conduction. It will not be traveling. In some of the skeletal muscles, if there is no activity, then they are lying, not doing anything. Cardiac muscles will also work only when they are said with them. Right? So they are also working under someone. But it is the pacemaker who is not requiring any motivation. That pacemaker is constantly for whole life, it keeps on sending the signals. So what is that something so fantastic in case of pacemaker that it is not requiring any of the motivation? So that's why there is RMP, but this RMP is not the resting membrane because pacemakers, they never rest. That's why it is very lovingly called as the restless membrane potential. Restless membrane potential. The whole life will never happen that all the pacemakers will stop because in our body there is a backup system. This is the SA node, which is right now working in you, me. It's working fine. For some reason, if anything goes wrong to the SA, there is a backup system that is what is called the AV node, atrioventricular node. So this atrioventricular node is not as efficient as SA node, but at least it will keep the heart beating. There is again a system in case if anything goes wrong to that, then there is bundle of hairs, then Purkinje fibers. Now these are the fibers which are conducting current to the cardiac muscles. But in case if anything happens to SA, in case if anything happens to AV node, so even this bundle of hairs, it can take over. No doubt, as we proceed down and down, the speed would be decreased. Right? They are not that efficient. They are not that efficient as compared to this other. This is the superstar acid. That is the best. Right? Okay. So, but they are pacemakers. So here also, AV node, remember, AV node, does cardiac cells replace? No. Cardiac cells, once they are dead, they remain dead forever. They are never replaced. This is the reason that if someone has suffered from any of the myocardial infarction, heart attack, 5 years back, you just see their ECG and you check and see that this is the case of past MI, myocardial infarction. Because its evidence will always be that particular portion of the cardiac muscle, right? That will not be dead, but it will be lying there only. It will never be removed. Brain and heart, these two cells, they don't they get missed. So this SA node This AV node is always interested that I also want to take leave. But when the message of SA node comes, AV resets. Okay, next time. Right? So for whole life, this AV node will keep on thinking, yes, one day will come when I but otherwise, the moment message comes from the SA node, it resets itself. So that's how things they really go. What the replacement of the pacemaker is, that is the artificial pacemaker. Now, in case if this pacemaker has gone wrong, so then this pacemaker, it can beat the heart rate at 72 beats per minute. However, this one, the heart rate would drop to 45 per 50 per minute. It's pretty slow. So that's why at times artificial pacemakers are. Artificial pacemaker is nothing but battery operated device, right? And it will keep on sending the pulse at a regular interval. The complete thing is wired. So instead of this natural pacemaker, this is the natural pacemaker. The artificial pacemakers are. This is a natural pacemaker. And now they have devised such batteries that once they are put into it, they run for 5 years. For 5 years. So it is not necessary that every night, right, they have to charge their pacemaker. So these are all artificial pacemakers. When we'll be discussing cardiology, we'll be talking more about various types of pacemakers are there. But one important word of caution. Say if your patient is subjected to, let's say, X-ray, no problem. You can take X-ray. Right? If you have to do CT scan, no problem. You can do CT scan. But under any circumstance, if he is subjected to MRI, it is totally contraindicated. Such person in which there is artificial pacemaker, right, they should never ever be subjected to MRI, because MRI is a very strong magnetic field in the range of 1.5 Tesla, and that thing will immediately fry up the circuits of pacemaker. The person would die on the spot. So that's why MRI is magnetic resonance imaging. So if you go into the technicalities, it is cooled by liquid helium at -273 degrees, which is considered as an absolute zero temperature. Now, at this absolute zero temperature, not one but the two pair of electrons, they start traveling. And when that thing is happening, it is something what generates a super powerful, they are called as the superconductors. Superconductors. When these superconductors are generated, the power is so much that they can lift the entire train. So all those magnetic levy trains, right? Those who are, there are tracks, right? There are tracks, but as soon as the train starts, right, the train will be 6 inches above the ground, and then it is moving, right? Then it is moving all the way, because that polarity, it keeps on changing, so it keeps on pulling the train, and then train without any jerk, it goes at that pace. Over here also, there are coils. So by the Faraday's principle, this is the core, and if these are the coils, so when you pass the current between these coils, so there will be generation. This coil would start, right? This inside core that will start moving, the principle of motor. And if you are moving it, right, so then it will be generating the magnetic field, right? The Faraday's principle. So that magnetic field that becomes so strong when the current is -2, when the temperature is -273, absolute zero. So that means the entire resistance goes down. In MRI, that's why in case of MRI centers, right, there are special walls, and if the person is, or the patient, everything is checked thoroughly. He should not be having any of the prosthesis. Prosthesis means what? Say, if someone has got the fracture, to then plate, nails, right? All those, they are called as prosthesis. Artificial hip joints. If it is metal, then MRI is totally contraindicated. Now, all those rods, metals, because even a small coin, that small coin will shoot like a bullet. It will shoot like a bullet. It is, this magnetism is so powerful. It is calculated in the range of Tesla, 1.5 Tesla. No, it won't attract titanium. Titanium is barred. Titanium won't be able, because titanium is non-magnetic. But Rest of the things. So that's why no electronics, none of the electronics, because those circuits, they are those semiconductors, so they will be just fried up. So pacemaker is considered as the biggest contraindication. Pacemaker. That was about it. Coming back to our main topic. So we have neurons, skeletal muscles, cardiac, everything which will be discussed. So when we say restless, when we say restless membrane potential, that is because it is not stable. It is constantly moving. So this is oscillating, or you can say it is fluctuating. It is oscillating or fluctuating because then and then, metal tooth, no, not allowed. Because those things, they are very dangerous because the pull itself would be very powerful. So oscillating or fluctuating. And so this can never be stable, because if the pacemaker comes to standstill, that means if the pacemaker comes to resting phase, that means it is not sending any current. If it is not sending current, then heart is not going to by itself. Right? It will stop. So that's why these pacemakers, they have got a special mechanism, which we will be learning later. But yes, this is just for the standing. So it is not stable. Minus 60 millivolt to minus 40 millivolt. So it will never come to a one normal baseline. It will keep on moving. Right? So that's how it keeps on sending the signals. Okay. Next is, there are some of the centers. So this heart is like one in which there is S node and AB node. Similarly, in our brain, there is a respiratory center. There is a respiratory center. And this respiratory center, that is into medulla. No, it won't affect. MRI won't affect iron in our water. Yeah, it will come. So in respiratory center, there is medulla, right? So this is midbrain, pons, and then the medulla. Think collectively what is called as the brain stem. And don't worry about it. This is the part. And in this, there is one center. That is the respiratory center. This is the respiratory center. This one. And this respiratory center, it keeps on sending the signals. So you don't have to really tell your lung, you don't have to tell your chest, come on, breathe, right? Inflate, deflate. No, it is constantly happening by itself. So that's why it is thanks to this center. Why we are talking about this center? This is what is called as the Botzinger. It's called as the Botzinger. That's a name, right? Complex. This area is the most sensitive area for hypoxia. Hypoxia means lack of oxygen. So in the entire body, if there is anyone who is suffering from hypoxia maximally, this center would say, whether others they get the oxygen or not, I should really get the oxygen first. So this is the reason that when we'll be studying the brain has got tremendous affinity for oxygen. It consumes almost 40% of the oxygen that is consumed by the brain only. Because it is saying, I can't survive. Brain cannot survive without oxygen even for full 3 minutes. While for liver, lungs, no worries. Even if anything happens, they regrow. Brain is not regrown. So it is the most sensitive. And out of that entire brain, this particular area, which is the respiratory center, is the still more sensitive, most sensitive of all. This is why that if the patient of heart attack comes, then first thing is, what is needed is the pressure oxygen, right? The pressurized oxygen is because pressurized oxygen, you see, he is not breathing, right? That person who is having myocardial infarction and the blood is not circulating, So it is the pressurized oxygen which will go into the lungs, into the alveoli, and forcefully it will go into the system, and at least system will survive. More when we'll be talking about myocardial infarction. But these are the some important points. So when we say we used that we use the Nernst formula, we use the Nernst equation or the Nernst formula for the equilibrium potential. So that was minus 61 upon Z into log of concentration of that particular ion, which is inside upon concentration of that particular ion outside. So this was giving us that equilibrium potential, right? It was called as the equilibrium potential. And what Nernst equation was telling that this equilibrium potential, that is for one ion. Right? So important is it was for one ion. So whenever we want to calculate for sodium, calculate it for sodium. But potassium, so no. The whole calculation goes again. That was the Nernst equation. And then we learned one more equation, that was Goldman's equation. Goldman's equation. So Goldman's equation, he considered all the ions together. So that was the major difference. Ions. And that's how things were done. Now, using the Nernst equation, when we calculated the equilibrium potential of sodium, so it turned out to be 60 millivolt. When it was found that equilibrium potential of, let's say, chloride, so how much is that? It was found that it is the minus 70 volt. So what is happening at this? So let's take this first. What is happening at 60 millivolt, plus 60 millivolt? At plus 60 millivolt, the amount of sodium which is going in is equal to the amount of sodium which is coming out. So practically speaking, there is equilibrium. Now they both have stabilized. Right? It is not so that now nothing is passing through everything. But if there are 1,000 units going on one side, then 1,000 units are coming out. Right? They never rest. They never come to standstill. It's constantly working. But in all those competitive exams, they ask you something, which people at times find it a bit tricky. So that's why I write that sentence. And the sentence is, this is what you have to just register in your brain. Because in exam, when it comes to, sometimes there is confusion. What I'm writing is equilibrium potential of chloride is equal to resting membrane potential of neuron. Equilibrium potential of chloride is minus 70. Let's go back up. And where is the neuron? Where is the neuron? Minus 70. So they try to. Similarly, if you say that what would be the equilibrium potential, so we can say, let's say in case of equilibrium potential for potassium is minus 90. We can say that equilibrium potential of potassium is equal to resting membrane potential of skeletal muscle. What are the relation? What they really do? Yes, we'll talk about it. But at least this part is clear. So in exam, if they say like true or false, so this is like true, right? Similarly over here, when we say about potassium, so it would be the resting membrane potential of, say, skeletal muscles or the cardiac muscles. So that's true. So we talked about Nernst equation, we talked about this Z, just a reminder, right? It was the ion. So whether it is sodium plus, calcium plus, so in this case, 1, in this case, That was Goldman's equation. Okay, so coming back to this, coming back to in fact our neuron. So what we are to our neuron, and in neuron we just see the synapse. Though I talked about it, but say this is the upper and this one is the neuron. So in between this space is the synapse. And as we discussed, this will be called as the presynaptic and this one is the postsynaptic neurons. Right? This is the pre, this is the post. So over here, all those neurotransmitters, they are into the form of vesicles. Vesicles means vessels. They are packed into all those small balls, right? They come to the surface, attach to the surface, and then they open up, and all these are released. But these neurotransmitters, as they are released, these are the receptors. So which receptor? Let's say the neurotransmitter released is acetylcholine. Right? It is acetylcholine. That means we have got the cholinergic receptors. Right? We have got cholinergic receptors. These cholinergic receptors, they will be stimulated because this will be acting as a ligand for it. Right? Acetylcholine is the neurotransmitter, it will be the ligand. So that means these are the receptors which are ligand gated receptors. So there is stimulation of ligand gated receptors. Simple, right? Crystal clear. And there are several. So every receptor sending a message inside. So then it will be leading to some changes inside. Right? Inside. So it could be gene, it could be ion channels would be open. So over here, as we said, the ion channels will be ion channels, right? They open. So far, any problem? All good?
So,
Go ahead.
so above means, can you just scroll it?
About what?
So above you have written, see, where equipotential of chlorine and was equal to RMP of neurons. Here, why have you written the skeletal and cardiac?
Because we said that equilibrium potential of potassium is equal to RMP of skeleton and cardiac.
Okay, okay. Yeah.
So that was the thing. Okay. So ion channels, they open, and once these ion channels open, you know that the potential will start changing. So that was the reason when we said that it is this neuron 1 in which there will be electric current, then it will be passing that current, that stimulus to neuron 2, but in between there will be the chemical synapse. Then again the electrical activity. Then once again there would be the chemical synapse and the process continues. Right? So 1 to 2. And this entire wave which is going, that is the action potential. Because it will be leading to some action. In general, we know this fact that in case of ECF, right, in our extracellular fluid, there is large amount of sodium. There is large amount of chlorine. And there is large amount of calcium. There are even other minerals also, other salts also. But we are just keeping this thing simple because these are the ions which will be using for our purpose. Right? So if they put nerve in the place of neuron, nerve in the place of nerve is what? What is nerve? Nerve is group of neurons. Nerve is group of neurons. So when you said if you put nerve in the place of neuron in the RMP of neurons, no, say the thing is nerve is one neuron to second neuron to third neuron to fourth neuron, right? It's a complete chain. So that's it. This is N1, N2 means this is neuron 1. Neuron 1, this is neuron 2. That's how they are. Brain tumor definitely affects these neurons, no doubt about it. It can affect in both the ways. Whenever there is any of the pathology, when we'll be discussing the pathology, we'll see this, that pathology acts in either positive way. That means the overstimulation, or it can lead to inhibition. If there is overstimulation, any of the pathology, if there is overstimulation, so let's consider the simple thing, there is a blood pressure. So if there is overstimulation, there is hypertension, increased blood pressure. And at times it is on to the next one. Now think it this way. Let's see. Now we are just expanding the synapse. This is the synapse. This is the synapse. So this is our presynaptic neuron. Perfect. And this below one will be the postsynaptic. So over here, there is release of neurotransmitter. Let's say this is acetylcholine. And these are the receptors which are available. And that acetylcholine which is released will come over here because this one is ligand. That's what it's a ligand. Right? So that's why we'll be calling this receptor as ligand gated receptor. From this point onwards, now this is like a continuous process. At any point of time, if you lose even a bit, immediately ligand gated receptor, as they are stimulated, right, they will lead to several things which we have already discussed. G protein coupled receptors, if they are stimulatory, right, those alpha, beta, gamma, right, that GDP then becomes GTP, then it goes to that adrenaline cycling and all those processes. Okay? But final effect is what? The final effect is what you are remembering is G. Right? The gene, ion, and the enzyme. So this is the time for those ion channels, they open. Yes, there would be some gene changing, there can be some enzyme secretions, right? Possibility, not every time. Over here, it is first thing which is taking is the ion. Which ions? Sodium ions. Sodium channels. So these are the, let's say, sodium channels. These are the gates, right? And these gates, they were remaining closed. This is the sodium channel. Those gates were remaining closed. Because of this stimulation, those gates have opened. When the gates have opened, the sodium moves in. Why should sodium move in? Sodium is more outside, less inside. When the gates are open, so then it's just flow. So the sodium has come in. Sodium has come in, that means it's a positive thing which has come in. So our influx of sodium, very true, I write it. Right? It is the influx of sodium. So when there is influx of sodium, that means cell will become positive. Right? Cell will become positive. So this is one. Things are not ending this much. There would be even other. There would be even other ion channels like calcium. Right? Even they can participate. And over here, apna potassium channel, so it is always there, right? Constantly throwing the potassium out because it is a passive channel. Right? This is a passive channel. But this sodium part starts. So it means that we were on minus 70 millivolt, and with the entry of the sodium, we are now going slightly positive. We move to minus 65 millivolt. Correct? So this is relatively more positive. When it is relatively more positive, that means less negative, so we'll be calling it depolarization. Depolarization. You might say that it is not much, not much of the difference, but this small difference is important, right? So this is what is called as the depolarization. This depolarization occurred because there was this area is called as the postsynaptic. Right? After the synapse, and this signal, what came, it increased it. So we call this EPSP, excitatory post-synaptic potential. So excitatory post-synaptic potential. So the current which is going, it is after the synapse. So this is what is happening. The next is, now there would be, so this is excitatory post-synaptic. Right? Let's learn a totally different, but it is important for the concept right now. Right? Just consider this page is bilkul alag, and this is where again same setup. The synapse, this is presynaptic, this is postsynaptic. Right? These are the receptors. From here, the vesicles, those vesicles release this into the synapse. That ligand came over here. This ligand, it came over here. When it came, it led to stimulation of the receptor. This stimulation of receptor, but this time it was stimulating not sodium, it was stimulating chloride. It opened chloride channels. Possible, no? Because these receptors are different. They open, these are the inhibitor, GI, right? So they will be opening the chloride receptors, chloride channels. So these chloride channels, which were normally, they were remaining closed. And as we know that outside there is more chloride as compared to inside. But when the stimulus came, that inhibitory stimulus, because this is the GI sort of, who is stopping it. So he is going and he is stimulating this chloride. When this chloride, then large amount of this chloride, right, that would come in. That chloride has come in. When this chloride is inside, what would happen? The cell is becoming more negative. Right? The cell is becoming electronegative. When the cell is becoming more electronegative, right? This is so negatives are coming from outside. So cell will be more negative. So from positive to negative. And this thing is called as the repolarization. So that's why when the negative cells are coming in, so that means they will what? They will damp the stimulus, because cell becomes excited when it becomes plus. Over here, negative ions are coming, cell is becoming more electronegative. So even if it was, let's just for the example, if it was say minus 65, it will now become minus 70, more negative. So when more negative, that is what is called as postsynaptic potential. Immediately post-synaptic. How repolarization? Minus 65 to minus 70. More negative, because negative ions are coming. Got it? Negativity is increasing, na? See, from positive to negative, or minus 65 is less negative, minus 70 is more negative. Right now, don't worry about the timing part for how and because there is a constant change, right? Step by step learning. Correct? What if the fluoride channel remain open for too long? Won't cell become minus 70 or something? That is what is said. When these channels open, this is just an example. And what difference does it make? We want the repolarization. We cannot keep on doing it just the depolarized, constantly stimulated. No, it has to come down. Right? Now we'll be combining these two things. So it doesn't matter. Because we can't just the cell, see, cell is stimulated, it is depolarized, and we keep the cell depolarized for whole life. So then what would happen? The muscle which is contracted, it will never release. Right? Many of the conditions, when the spasm occurs, so what really happens? So for example, when they detect that just by looking at the person, that before this person died, you will be learning it in forensics, but just by touching that person and examining his muscles, you figure out that this person died before what time, how many hours back, because of the rigor mortis, situation of rigor mortis. That is, after the death, one by one muscles, they start going into the spasm, right? Because they are remaining into the depolarized state. They are not coming into the repolarization. So once they are contracted, and let's say if these chloride channels, they are not opening, so then that cell will remain into that state. He will not be relaxed, and that will go into the spasm, right? Or ulta. If there is no stimulus given, so then that muscle will always remain into its flaccid condition, soft condition. So there is no impulse which is telling a come on, contract. So this is excitatory. Either the excitatory is absent or the inhibitory is absent. Both are bad, right? Because we require a constant cycle, right? Say for example, heartbeat, contract, relax, contract, relax, contract, relax. That is what is needed. So that's why it's not so that only excitatory is important. This inhibitory is equally important. That's why I took this thing. Because now we'll combine both of them. Omkar, clear? Right. Should be crystal clear, right? So just remember this. Now we combine both. And first, that this is what you have to learn. We'll be drawing now from this point onwards, we'll be drawing several graphs, only the graphs. You have to just visualize, yes, right, this thing should happen. So here is the first one. The first one. Minus 70 millivolts. So that means this is our resting membrane potential in vitro. This is our resting membrane potential. This resting membrane potential, and this is, let's say, minus 65. And this one is, let's say, minus 55. And just draw lines everywhere. Oh, now we change the color. Here is our first process. This is our resting membrane potential. And from resting membrane potential, the cell is becoming more positive. Cell is becoming more positive. Why? Because it is this portion when those potassium leaks are. Potassium is, right? So this is resting membrane potential is formed. Right? Resting membrane potential is done. And this minus 70 to minus 65. Correct. So minus 70 to minus 65, right? This is where things would start. That initially we have got the sodium potassium pump and the potassium channels. They are working, right? They are working, and they will work so that they just raise from -70 to just -65, right? -65. This is the point. This is the point, right? When it is a slow process. It is a very slow process. These are all the leaky channels. Slowly it reaches to this point. Now the stimulus has come. When the stimulus has come, so from -6, right, over here, the stimulus has come. Sorry. Just. So at -65, there is EPS, excitatory postsynaptic potential. So it means at this point of time, because of the release of neurotransmitters, the sodium channels will open. When the sodium channels open, it will start gushing in, right? So it reaches to this level, -55. So this level is what is called as the threshold potential. Threshold potential. Threshold is what? Threshold means one limit. If that thing is reached, then the shoot, a big shoot will happen. Right? So what we need to understand is that over here, this is because of the sodium channels, and it is happening because of the sodium channels, and it is ligand gated. Ligand gated. Because of the neurotransmitter, it is happening, and it is slow. This is a slow phase. This is a slow phase. Now something happens at the threshold. At -55, something different happens. And what that is? At -55, again there are sodium channels. Right? There are sodium channels. But these sodium channels, they are not ligand. These sodium channels, they are voltage gated. Right? Voltage gated. And these voltage gated channels, they are super fast. They are fast. So the moment -55 millivolt is reached, in single shot, these opens and they shoot. Because large amount of sodium, they will open because they are controlled electronically. Right? So voltage gated, that means electronic control. So that electronically controlled, so those number of channels, they will open and they will just dump the sodium in large quantity into the cell. So immediately it will start rising, comes plus. So the point is that ligand gated sodium channels, they are slow. Voltage gated sodium channels, they are fast. The function of ligand gated sodium channel is to take it to the threshold level and then they say apna kaam karna. From here, it is the voltage gated sodium channels, and they will go all the way up. Is this part clear? So the game of sodium, slow sodium and the fast sodium.
So
now what happens? All right. So now something happens. Something happens at.
excuse me, sir.
Yes.
So when it reaches 55, so Na opens and Na shoots, right?
At 55.
Through the voltage gate, it is a fast process, and downwards is the slow process.
Correct. Correct. Because
Right.
I'll just draw. I was about to draw and explain also. So
okay, sir.
Here it is. This is the inside, right? Inside. This is like we are dealing with right now post-synaptic, right? Post-synaptic. So here is the synapse. Here is the synapse. And our receptor is over here. So ligand came, right? And it said, so we have got, these are the sodium channels, right? And they were closed. And then we'll change the color. Change the color. These are our fast sodium channels, but they all are long. They all are long. So when the neurotransmitter comes, it tells this channel open. So this will open. It will open and slowly, right? That slowly they will start coming inside sodium. So this is where it is at -65, and because of the presence of this, it will become -55. The moment it becomes -55, all these, they will say, yes, that's it. 55 was the trigger for them. So open, and then comes the gush of sodium in large quantity, right? They just enter. So this sodium, this is in large quantity. So that's why the whole graph will become like this. This is the resting membrane potential, 70, right? It went to 65, to 55. So this from -70, it reached to 65, sodium channels opened, and it went slowly. And over here, the shoot, this is how. So after -55, there is rapid influx of sodium, and before that it is slow. Absolutely, very cool. You are 100% right. So that's why we'll be writing from this time onwards sodium fast and sodium slow. But always remember, electronic systems, they are much faster than the physical systems. So over here, they are fast because these are voltage gated. Right? Voltage gated. They are operated by voltage. Slow is ligand and fast is voltage. Perfect. That's right. And this one is the ligand. Right? Whatever the ligand is, acetylcholine, whatever. But they are slow. These are fast. Now what happens? Go back to this, there is a potential equilibrium, right? Yeah, here it is. There is equilibrium potential of sodium at 60 millivolt. So it is not so that now, see, can you visualize? If you really think, right, you will find, yes, it makes complete sense. Why Nernst equation was a wonderful thing. Channels are open. Right? Once the channels are open, right? Sodium, they will start dumping. They'll start coming. But till what point? At one point, when there will be equilibrium established. Because bahar to sodium is sodium. There is so much of sodium, right? But not everyone is allowed. There would be the equilibrium. Exactly. I was expecting this word, right? So there would be the equilibrium. So initially, the graph would be going like straight, and then it will slow down. Then it will slow down. At one point, it will say, now it will be no more sodium can go in. And it is from this point where it has to drop, because then someone else will come. Some other channels, they are triggered at this point. They are none other than the potassium channel. So there are voltage gated potassium channels also. So they will open up. When they will open, so they will start throwing potassium out, and then this whole thing will come back into the repolarization. Right? So this is the thing, that this portion, it is called as the depolarization. Depolarization. And then the plateau is reached. Plateau means peak. Plateau is reached. And at this particular voltage, when the sodium would say, my work is over, and sodium channels will shut down. Right? Because when they'll say, our voltage our equilibrium state has reached, so they will shut down. And it is at that point when the potassium will come into picture. Right? It will say, now it is my turn. Because potassium channels, they are triggered at that high voltage, and then they will take the entire thing down. After equilibrium, sodium is still in. See, those sodium, though, it has come in, right? And the channels are closed. So at this point of time, in the cell, sodium is present. Who has thrown them out? No one. what is important is that right now we are talking about the potential difference. That means inside we have got the sodium, inside we have got the potassium. It will say, forget about everything. Throw the positive ions out so that we become negative, so that it relaxes. It is over here into this area when they say, chalo, finally we do the exchange. Right? The way friends, they go for the picnic, तो एक बार इसने पैसे खर्च किए, एक बार इसने पैसे खर्च किए, right? But then वापस आके after we come back from the picnic, we say, अच्छा तूने कितने किए, इतने divide by 3, right? तीनों तीन के इतने होते हैं, right? मैंने सबसे ज्यादा खर्चे, तो लाओ difference मुझे दो. So that is the exchange which occurs, and this is where the sodium potassium pump comes in. This is the reason that you must have noticed that the sodium potassium pump is throwing 3 sodium out and 2 potassium in. So you must have wondered why this imbalance, right? 3 sodium bahar, to 3 potassium andar. So how wonderful? No, because of this, so much of potassium it has gone in. So that's why sodium potassium pump will work and will be able to clear out the sodium at a faster rate, because we cannot rest. I mean, next cycle is also there. Next cycle is about to come. So before the next cycle starts, it has to reset. So that is the function of sodium potassium pump. That is the reason that sodium potassium pump can never stop. It can never ever stop, because the moment it would stop, it will stop this reset mechanism which is occurring over here. And if that mechanism stops, cell dies. Right? Nothing can be done. So still more is yet to come. So now you can imagine that what would happen in cardiac muscles. Completely different thing. What will happen to skeletal muscles? It is like a completely different game, right? But this foundation, which will be carrying for everything. Now, still, we are dealing with the neuron, right? Now, so still more to come. Here it is. What we are drawing is axon, right? So this is what is happening at axon hillock. Axon hillock. Axon hillock is nothing but just this. Let's just draw it. Axon hillock was here. This thing, this junction. Right? It is called as the axon hillock. So something is happening at axon hillock, and after axon hillock, the myelin sheaths are there. Right? Keep that thing, and we just change the orientation. So now this is how. So here are our myelin sheaths and the nodes of Ranvier. Right? These are the nodes of Ranvier, you know that. And this one is the axon hillock. Right? So what happens at the axon hillock? Axon hillock, this is the area where it is loaded with millions of sodium channels, and these all sodium channels, they are voltage gated. However, over there, these were the sodium channels which were ligand gated. You got the idea, right? So near the synapse, there are sodium channels, but those sodium channels, they are ligand gated, because they will be operated by that receptor which say, chalna, open, right? Aane de sodium. I'll write. Just understand, then I'll write. Right? So this is the synapse. So at synapse, the receptor was there. So this receptor got activated. It said, yeah, follow, right? Open the sodium channels, right? And the sodium started. So from here, slow leakage of sodium. I write down, these are the ligand gated, right? Ligand gated sodium channels. And this is the synapse. So at synapse, ligand gated. But then that sodium has to come in. So then that sodium, it comes inside. Sodium comes inside. So it is changing the voltage, right? And at axon, right, they all are ready. They all are ready on both the sides, right? They are loaded. And as soon as the voltage strikes -55, and then there is rapid bombardment, right? The rapid bombardment of sodium, right? They start within split second, right? There is large amount of sodium which is present over here. This is all, everything is happening at axon below. And now it is necessary that this thing should move. So from this point onwards, it is the electrical system. Till this point, it was the chemical. Now starts the electric. Right? Sure. So these are the voltage gated, correct? Voltage gated sodium channels at minus 55. So from here, the action potential moves. Right? This action potential moves. So it goes further. And this is the myelin sheath. So myelin sheath is telling that this signal should not be damped, right? And it should move continuously, etc. But then what is the role of nodes of Ranvier? These are the nodes of Ranvier. And what did we say for the nodes of Ranvier? We said that they consist of what? Nodes of Ranvier, they consist of what? They consist of large amount of sodium channels. Correct. They have got, in fact, they have got the maximum sodium channels. So why are they needed? The answer for this is that this myelin section, we just draw So here is the myelin. When it is myelinated, right, this myelin sheath is there. It won't be going like a normal conduction. Myelin sheath leads to jump of the potentials, jump of the electrons. Let's see that how they really go. See, when this is myelin, right, and here are the sodiums, right? Sodium has come and it reaches to this point, right? Those positive ions, they reach to this point. Now, in case of myelin, there is arrangement of these positive ions already there, right? So this positive ion would hit this positive ion. That would hit this one. This one would hit, this one would hit, and so practically speaking, this is like as if the ion which is that positive is over here and it straight away it jumps at this point. So this is a sort of jump and its speed is much higher. It is 75 meters per second. This is the speed at which it travels, 75 meters per second. Amazing speed, because entire body, right, it won't take even 0.1 second, because body is not 7.5 meters, right? So it won't take even split second. That is the speed at which it will start moving. So the point is, always think it like that railway wagons, they are there, right? Railway, the bus. They are. So yahan pe one push, right? So then dhakar, right? That push will transfer all the way there. So inside myelin already sodium is present. Yeah, that's right. So they are already there. But there are no channels, right? There are no channels. Just to remember that in the myelin area, there are no channels. But yes, over here in the nodes of Ranvier, there are sodium channels. Right? So these channels, so what happens that when this comes over here, these are once again voltage gated. For some reason, even if there is slightly, let's say if, because these channels, so they are very strict regarding the voltage. Let's say it happens like that over here, it is minus 55 as reached, right? And if it reaches over here, it drops to, let's say, minus 59. Now this, it won't work, right? But because of this, because of number of sodium channels, right? Again, new sodium will enter and it will enhance the signal, and once again it will give dhakka to this and it will keep on moving. So the signal becomes stronger and stronger as it goes. Right? This is the beauty of this nodes of Ranvier. The node of Ranvier, that a signal never dies. They never let the signal die, and second, it gives the speed. So once stimulated, so it is minus 55, the minimum is maintained. As such, it is much higher because the entire unit, it goes into the positive state, right? It goes at a positive level, right? Because the conduction which is going on, it is not at minus 55 was the trigger fire, right? Then to these sodiums, they have entered, so it took all the way to the plus. So they cannot be brought down unless other ions will come and they will take it down. So say this amplification system, it will keep on increasing, right? The signal, more and more powerful signal will go. And that's why this entire mechanism has been given a special name, and that is what is called as the saltatory conduction. Saltatory conduction. This is called as saltatory conduction. So in which more and more sodium channels will open because of the voltage operated, right? And they will keep on gushing. So signal never dies. What if this myelin sheath goes wrong for some reason, right? It will slow down the whole conduction. Myelin sheath will slow down to that level that entire movement of that person will be slowed down, right? We'll take that clinical at the end. In the meantime, let's talk about because now we have to even close the sodium channels. So this is true for any of the channel. So these are like voltage gated. We are right now talking about sodium channels, but just consider that this is true for even other voltage gated channels. There are 3 states. So these 3 states, one state which you can just think it like this, closed. Nothing can pass through. Second state, you can just say that this is the open state, right? Open state. Things will be passing through easily. The third stage, this would be interesting. The third stage, it is called as the inactive state. Now in inactive state, this is open, but it won't function. Right? Why? There is a block. There is a block, right? From both the sides. No doubt, this thing is like, depending upon their molecular structure, it changes in such a way that it blocks. It is not allowing sodium to pass through it. Over here, these blocks, they are removed. They are displaced. So those blocks, they are displaced. So that's why it functions. Over here also, they are not active because the channel itself is closed. But over here, in case of inactive state, those molecular blocks, they will arrange themselves in such a way that they won't allow sodium to bind on either side. So it won't let it pass. When this thing occurs after depolarization. After depolarization. Right? So after all the hard work, right? The hard, sodiums they have entered, and then as it reaches to plus 40, 50, and then the equilibrium is reached, block. The sodium channels, they are not closing, they are blocking, right? So they will be blocked. And then they will go back to this closed state. When? After resting membrane tension. Till that point, these voltage gated channels, they won't operate. Right? They won't operate. This is the foundation for what is called as the refractory. Refractory period, it is one of the very fine thing when you'll be discussing, when you'll be treating a patient of cardiac arrhythmias. Say for example, he is atrial flutter or atrial fibrillation. In atrial flutter, what is happening? The heart is beating like this, at such a high rate. You want to slow it down, right? So that signals are coming, right? But you want to tell the heart, don't listen to them, right? Don't listen to them. No, tachycardia is okay. Is when you are doing the exercise, then also there is increased heart rate. Fibrillation or flutter when it goes into the range of 200, 250, 300. Right? When the heart is beating like this, tachycardia is this, the blood is getting pumped. Flutter is like that pakshi, right? Bird. He flutters the wing like this. Right? So when the heart is going like this, heart is not pushing the blood. So flutter is practically a useless thing. Right? It is in fact deteriorating for the body. Right? Because blood is not getting pushed and heart is just bichara mar raha hai. So it is at that point when you have to tell the heart, don't listen to that pacemaker, right? If he is sending the signal, don't listen. Just skip, please, 3 बार बोले तब एक बार सुन. So then heart will say, okay, heart is doing like this, and आप बोला 3 बार बोले तब एक बार सुनना. So 1, 2, 3, 1, 2, 3. Now the heart will go like that. That means you have put it into that refractory phase and you are told that don't listen. The whole concept is because of this. Now we'll combine everything whatsoever we learned till date, right? Till this point of time. In one graph, we'll combine everything. Right? So we'll combine, in this page, we'll combine the voltage gated, we'll combine ligand gated, voltage gated, the plateau, then what happens to the potassium voltages, depolarization, repolarization, hyperpolarization, refractory period, absolute and relative. Right? Everything, but it is in one sequence. So in single shot, you will be able to understand. Let's start. So here is our graph. The journey starts. And the trigger has come. Right? The trigger. So this trigger. So till this point, it is the ligand gated. Ligand gated. I'm not writing gated. Write it ligand. So this is slow. And then comes this, a fast one. So this is the voltage gated. This is depolarization, right? Rapid, fast, right? And then from that point, so this is where sodium channels, they are. When we say this, so that means it is inactivated. Right? It is inactivated. And when we say, we write it like this, that means it will be closed. Right? This would be our convention. So this is where the equilibrium, right? Because of the equilibrium of sodium is established. So the channels that would be deactivated, right? Inactivated or deactivated. So this is very important. Right? It is deactivated and it will remain deactivated till the RMP, resting moment potential, is reached. So now sodium cannot enter. Sodium's game is done. Now comes it is at this point. It is at this point now the potassium comes into picture. The voltage gated potassiums, they open, right? And the moment they open, what would happen? The potassium which was inside, right? It is in large quantity, it will start going out. So when it is start going out, cell is losing its positivity. So that cell will become negative. And this is what we call repolarization, right? So this is repolarization. Make sense? Repolarization. Repolarization. But the potassium channels, they are so enthusiastic, right? So they will take it even below the resting membrane, right? Take it below the resting membrane. So when the resting membrane potential is reached, the level at which it is reached, let's let's say this is reached. So from here, right, the fall which was below, it is called as the hyperpolarization. Hyperpolarization. So when it falls even below the resting membrane potential, then it lifts and it takes to the RMP level. Right? That is what it really happens. Now, what you need to know about is refractory period. Say this is deactivated, right? We told that sodium channels, they are deactivated. They are deactivated till the equilibrium potential, till it reaches to this point. So it is that this point when the sodium channels, they were activated, right? So at that level, this is this area, this time. This is called as absolute refractory period. Absolute refractory period. Refractory period means during this phase, if you give another stimulus, it won't work. Right? Absolute refractory period means you give any strong stimulus to any of the level, it won't work because the channels, they are deactivated. So that is what is called as the absolute refractory period. There is another refractory period which is called as the relative refractory period. Relative refractory period means right now the time has not come to start the second impulse. But if you give a stronger signal, it will work. It will start contracting. So it is this point onwards. Right? Because now, as such, if you technically see the sodium channels, they are deactive. They are closed now. Am I clear? Sodium channels over here, they are now closed. Right? They are now closed. So closed means if you give stimulus, they will open. But when they were deactivated, that means you do whatever you like, they won't work. They are deactivated. Right? They are not listening. So now over here, they have started listening. So you tell them open, give them the stronger stimulus, they will open. And that's the reason that the phase after this, this is the phase. This is the phase which is called as relative refractory. This is the phase, relative refractory. So in relative refractory, because the sodium channels are closed, so this entire game is of sodium channels. Potassium, so it is just opening and taking the whole thing down. But it is the beauty of those sodium channels. Ligand gated, slow, voltage gated, they fire. At the top, they are deactivated, so now they won't listen to anyone, and then potassium takes it down. As soon as the resting membrane potential is reached, these channels from the deactivated, they become closed. That means now they will listen, right, if the stronger signal comes. Otherwise, if the stronger signal is not coming, they are lying normally. Potassium will take all the way down, and then the sodium potassium pumps, they will reset, and then they will take resting membrane potential. So it is this area when the sodium potassium pumps, right, it will reset the system by throwing more sodium out and taking less potassium. So it will adjust, right, rapidly. So, and then the entire neuron is ready for the next firing. So this is absolute refractory period and the relative refractory period. Right? When we say absolute refractory, that means no response at all. Irrespective of the stimulus. In case of relative refractory period, stronger stimulation activates. In stronger stimulation, then the new pulse, the new phase would start. Any question, any query about this particular diagram at this particular page. Because if you have understood this page, then trust me, rest of the physiology will become so easy. Good. All clear?
Sir,
Yes, go ahead.
during repolarization, it is somewhat opposite of the sodium-potassium pump, right? And
During
then after,
polarization,
and
can you repeat?
during repolarization, the Na plus gets inside the cell and K plus is thrown out. So it is
No.
huh?
During depolarization, sodium is coming in, that is true.
Yeah, sorry. So
Potassium,
that
how
is
can
somewhat
potassium
like,
go out? Potassium channels, so they are closed. Potassium channels, they open at plus voltage at this high level. Otherwise, they won't open. So, think, no problem. See, here is the cell, right? Resting membrane is there. The stimulus comes. Now, we'll be doing it the diagram. So, the ligand has come. Ligand has come, it will open these slow channels. It will say, chalo, sodium, right? Sodium is coming in. Sodium is coming in, so it will raise it to minus 55 millivolt, right? From minus 65 to minus 55 it has reached. Okay? This is slow. But when this thing is reached, so then these are all high speed sodiums, they are sitting over here. They were waiting for this 55. And as it happens, then rapidly they will pump large amount of sodium over here. And we get depolarization. And we have reached to plus 60 millivolt. We have reached to plus 60. Now it is at this point, right? Because the sodiums, they are just coming in. So we are becoming positive. So that is the depolarization. Potassium, they are not working over here, right? Potassium ki bari to ab aayegi. When the potassium channels, these potassium channels, they are also voltage gated, right? These potassium channels, they are also voltage gated, but they activate at this plus 60. When they are activated, now they say, now it's our turn. So they will start throwing potassium out, right? Because there is large amount of potassium present inside. Now, that is, more potassium is inside, right? During repolarization, potassium move out of the cell, correct? And after hyperpolarization, sodium resets the cell for next repolarization, correct? Right? And yes, you are right. And over here, at this point, this is inactivated, or you can say deactivated. Correct? And this thing will lead to repolarization. And very rightly, what you said is that this is the repolarization. And so because they will be throwing so much of potassium outside, so the cell became very negative. And it is at this point when it has dipped down even to minus 70. So this is where the sodium potassium pump falls down. So he'll throw 3 sodiums out, 3 sodium out, and 2 potassiums in, and at that high speed, it will just reset the whole system. So system is reset, and then it's ready for the next cycle. But the point to remember is this, that it is during this phase there would be absolute refractory phase. Like nothing can be done, and it is during this rest of the phase, that would be called as the relative refractory, that the stronger signal, it can go for the next cycle, right? It can initiate the next cycle. You'll be coming across, you'll be coming across certain words, right? When we said one, we discussed the refractory period. The refractory period. Then there would be one more word in refractory: absolute, and the relative. Right? So over here, stimulus, no response. And over here, stronger stimulus, there will be response. The second word, which is what is called as the latent period. Latent period. Latent period, in simple words, it is nothing but delay. Right? Latent period is delay of response. So this means you have generated the signal, right? And then you are getting the response. The time which has passed in between, right? Time in between, this is nothing but the latent. So that's why in certain states we'll be requiring a very less latent period, because things should move fast. In some of the cases, if the latent period is more, we are quite okay with that, right? So this is what we'll be watching as it will be going from time to time, right? Depending upon that issue. We said about the myelin sheath. This is I'll save this PDF and I'll be putting it into our shared folder. In case if you are not having that shared folder with you, this is the email address. Just send the mail to me till you, right? It is continuous. Right? Just for the understanding, I'm writing this. PILLURMBBS@gmail. Just send a mail to me. I'll send you the link, and that link will remain same for our all the notes. Just send a mail, because right now it is not open, right? So I have to just send a mail. I'll send you the link. Coming back to this, the last part. We talked about myelin sheath. Right? We talked about the myelin sheath. Now these myelin sheath, sometimes because of some autoimmune disorders, right, they degenerate. So this is like autoimmune. Autoimmune means where body starts destroying its own cells, right? So that is what is called as the autoimmune disorder. Immunity is one of the superb topic. So once we complete this thing, I'll be taking about 1 month only for the immunity, in the complete detail about all the immunoglobulins, all the major histocompatibility complexes, how spleen works, how lymph node works, what is their circulation, what happens to all different type of WBCs, what happens when there are various types of immunity. One immunity in which this is just like cell-mediated immunity. In one, when the infection occurs, body sends the rapid action force, right? They destroy, but then a call comes that these are the type of bacteria. So you'll just check it from its database that this is into our memory, act accordingly. All those things, they are generally considered as very complex. And we'll try to understand it as if it is some mission, military mission. And every character will be given some name, and then you will understand that yes, this is one of the easiest thing and the most fantastic. Importance, diagnosis. When you will be going for the diagnosis, it will be very easy. And especially when you will see the reports, crystal clear clarity will be there that yes, this report means this report means this. That means if someone tells that, okay, hemosiderin is increased, okay, you know that it is because the hemoglobin has been broken. That hemoglobin which has been broken, it has broken into iron and the globin component. And this iron, when it matched with apoprotein, it led to ferritin. So many ferritins, they combine together, and that leads to hemoglobin. That's the reason hemocycle is more. So that the entire sequence will come into your mind. Right? So we'll take that thing in wonderful details, because it happens like, I'm not telling that you won't be able to understand when you read from the book. You are smart enough to understand, but it would take so much of time. Instead, if some things are given, because that's the responsibility of teacher to make the things simple, right? Otherwise everything is. Coming back to this autoimmune disorder, why it is the favorite topic? Because this is the process when the immunity of your body, which is the defense system, so powerful, the same immunity in case of that patient, that immunity is working against his own body. Right? So what that does is that in our body, myelin sheath, they are well protected. If someone tries to attack on it, right, our immune system will destroy them. But in case of that patient of the disease is called as the multiple sclerosis. In case of patient of multiple sclerosis, it destroys its own myelin sheath. It is like degenerative myelin destroyed. So when the myelin is destroyed, what would happen? It will lead to decrease into that saltatory conduction. The conduction which was occurring at the speed of 75 meters per second, right? That was the importance of that myelin. Sodium potassium pumps are working, right? They are working, but that myelin sheath, the conduction, right? You are able to generate the potential, but that potential should cross, no? Because we have got the nerve. So over here, nothing wrong in the cell, but from here, this axon, the current which was good, right? The chemical part was fine. But this part, this electric part, that slows down. So it leads to very sluggish movement, very sluggish, right? That person would be moving his hand also like this. Right? We should not make fun of anything such person because it is their majburi. But that particular person, he was in our college and he used to take about 1.5 hours to eat one masala dosa. Right? We were to Rakshas, right? We 4 friends, we used to finish one masala dosa under 1 minute, right? Yeah, that is true, right? And but he would really cut and then slowly, right? The hand movements will also be like this, as if you are watching the whole movie to a super slow motion, super slow motion. So that is what leads to what is called as the sluggish. That's the importance of myelin. One last thing before we close our today's close for today. Minus 55 would true, even that maintenance would be difficult. Actually. For the myelin, there are specific myelin forming cells. These are called as the myelin forming cells. And their characteristic is very typical. You need myelin into the central nervous system, that is when we say CNS, so that means brain and spinal cord. Right? Because in spinal cord, there will be big tracts, right? Those tracts, they are taking the message at a lightning speed to the brain and back. Whereas lots are slow, so that we, that's right. So CNS, and the second one is what is called as the PNS. PNS is peripheral nervous system, that is when we have got all those nerves, right? End nerves, peripheral nerves. The myelin forming cells, in case of central nervous system, they are called as the oligodendrocytes. Oligodendrocytes. Right? You need to remember, because when you'll be learning histology at that point, I'll show you all these cells, right, how they look like. But it might happen that when we are discussing histology, we might not come across this point. But do remember, so these are oligodendrocytes. And when it comes to PNS, they are called as the Schwann cells. Schwann cells. The typical characteristic of both of them is that in case of this oligodendrocyte, the ratio of myelin is to axon is 1:30. While in case of Schwann cell, this particular ratio is 1:1. What does that mean? What exactly? It means 1, 2, 3, 4, 5, 6, 7, right? Up to 30 axons are there. And then all of them they would be packed together. They would be packed together in a single myelin sheath. This is the typical thing what you will be seeing in the form of tracks, right? When the track of gall and ball duct, when they are traveling, so then that entire thing has got one single sheet. So it is like a one pipeline in which, and then there is a common insulator. When it comes to Schwann cell, the ratio is 1:1. It means that if we have got 1, 2, 3, 4, so then everyone will be having their separate myelin sheath. They will be having their separate myelin sheath. This is the difference. The ratio between myelin and axon sheath. So that's it for today. Do send a mail. I'll send you the link, and I'm storing this file. That location. All right. So let's hope that those two countries, they don't fight. Thank you and take care. See you next time. Which country?
Thank you, sir.
You don't know the country? पूरी दुनिया पागल है. Israel and Iran. All right. Thank you so much and take care. See you soon.